So they'd rather bring their relatives to faith healers first, and there might be a dwarf that has, or it might have been somebody cursed my relative before being brought to a psychiatrist for proper treatment. Hi guys, I'm Dr. Carmina Bernardo. My clients also call me Dr. Charm. I'm a psychiatrist and a toxicologist, and my specialization is actually bipolar, mood disorders, and anxiety disorders. I'm from Makati Medical Center of the Philippines. Depression, this is a mood problem that actually makes people feel very low or very sad. Of course, there are certain activities or maybe there are certain events that will make us sad. Like, for example, if a favorite pet died, of course, all of us will be sad. The thing is, with us, normal individuals, after 3 or 4 days, it will lift. Our mood will lift and we would be able to go on with our lives. But with depression, it stays for quite some time. And this time is around 2 weeks. If it's more than 2 weeks and you're still feeling low, you're still feeling sad, you're not able to get out of your room, your functioning is already affected, you're late for work, you don't go to work, you don't even bathe, then that is depression. One major criteria is what we call anhedonia, or the loss of pleasure in doing things that were pleasurable to you. For example, if your simple pleasure is just watching the TV, is movies or TV, but afterwards, if something happens, then you find that you're not interested in doing these things anymore, then it could be a sign of depression. Of course, others will be, problems with sleep, problems with your appetite. Sleep, it's either oversleeping or not sleeping at all, insomnia. With appetite, it's also lack of appetite or overeating. That is a problem. Of course, you cannot concentrate. You feel so lethargic. You have difficulty dragging yourself out of bed. You feel so restless also, maybe a little bit of irritability. And of course, most important thing is that if you're considering hurting yourself, or you have thoughts like, maybe it's better if I'm dead. Maybe it's better if I'm not here anymore. And one of the most common things that I hear right now is that, Doctor, maybe it's better if I'm not here anymore, I just disappear. So those are the things that are associated with depression. And of course, all of this would occupy at least 2 weeks. And then, as I've said, your functioning is affected. Okay, so of course, when you're depressed, your family will notice, or you yourself will notice, and you will be brought to a doctor, or you will bring yourself to a doctor, a psychiatrist like myself. Then, when a psychiatrist would evaluate you and would see that you have depression, you will be started on medications, and we call these medications antidepressants. As you said, it's antidepressant, so it's really for the depression. Now, for symptoms of depression, while you're on an antidepressant, antidepressants don't actually act immediately. It acts within 2 weeks. It's not like antibiotics. Within the first 2 or 3 days, it will act immediately. But for antidepressants, it takes around 2 weeks for the medication to be in your system before it actually works. Now, if it's already 2 weeks and it's not working yet, because the first things that you would notice is that your sleep is getting better, you're having more energy, your appetite is back. If that is not there, then the psychiatrist can continue it for at least 6 weeks. So it's about a month and a half. But still, if you're not improving, then the psychiatrist will shift you to another kind of an antidepressant. If there are 2 trials like that your symptoms are not improving, and with adequate treatment options, the treatment that was given to you, then we will term it as treatment-resistant depression. So up until now, the answer to that is still unknown. The medical community, especially international community, the researchers, still hasn't found the perfect medication that would address it. That's why we have what we call treatment-resistant depression. Still, at the start, it will still be your antidepressants. That will be like the basic that will be given to your patients. But later on, if they're not responding, then some psychiatrists would add other kinds of medications. And when I say other kinds, would be maybe antipsychotics that will help. Others would be mood stabilizers. Other would be anti-anxiety medications. So those are right now our baseline treatment options for our patients with major depressive disorder. So now, when it comes to when we say treatment-resistant depression or for depression, the thing is why we don't have the answer to that yet is that, of course, we cannot do live experimentation or, live, getting some brain matter here, extracting some fluids there. We can't do that. Unlike in other other conditions wherein there are certain parameters that could be measured by the blood, or done by your CT scan or your X-ray. With psychiatric illnesses, where all psychiatric illnesses, unfortunately, we won't be able to do that. We go by our criteria wherein we establish a diagnosis. Now, of course, when you do that, your treatment options are sort of like limited because it will depend on the researches that would come out. So, with the current crop of medications, it actually only addresses 3 chemicals in the brain, and this, you could research this. It would be your serotonin, your dopamine, your norepinephrine. So this is not enough. This is what we're seeing. Why? Because 1/3 of our patients actually don't respond to these medications. So always, there is a quest to find other pathways, other chemicals that are involved in the brain when it comes to depression. One of our treatments for treatment-resistant depression is a new medication we're calling esketamine. It utilizes a different pathway in the brain. Okay, so what we found out is that with antidepressants and by using esketamine at the same time, we can actually see results within 2 hours after administration of your esketamine. Another thing that differentiates this from your typical antidepressants, because antidepressants, these are all taken by mouth. They're all in tablet form, so you need to take it orally. But with your esketamine, this is one of the newest, medications that we use for treatment-resistant depression. We actually administer this intranasally, so we utilize the nose. So inside the nose, a little bit of anatomy here. It's very vascular. There are a lot of blood vessels. So once we put it in, it goes through the blood vessels and immediately it goes to the brain. That's why it's able to give its effect almost immediately. So, like for example, if we have like a rating scale for depression wherein a score of, like for example, 20 is considered already moderate depression, this is a scale with a lot of questions pertaining to depression. By the end of 2 hours of the monitoring, the score is actually 0. Meaning the patient has no depressive symptoms at all, doesn't feel anything. So we have that option. And I'm very proud to say that it's actually, we're second in Asia. And it's actually the first, Makati Med has the first esketamine care center in the whole Philippines. So we would be able to administer and help our patients with treatment-resistant depression. There is a device. It's like when in asthma, you have like your nebulizer. So you press it, yeah. For 2 into each nostril, yes. And after 2 hours, it's like the score is 0. And the patient you can actually see the face light up. Unlike traditional antidepressants wherein we expect to see initial improvement in symptoms in about 2 weeks. With esketamine, we actually see improvement in like 2 hours. Another is like, again, like for it's oral medications, but for esketamine, it's intranasal. So maybe patients or your clients will be asking, what about the side effects? Because for your oral antidepressants, it would maybe be like just a little bit of diarrhea or maybe some restlessness. Well, that's why we have the monitoring of 2 hours. So 2 hours, the patient will be with us and there will be a doctor and there will be a nurse monitoring them because usually it's only transient. It's while those 2 hours are being monitored, there may be some transient increases in your blood pressure and maybe some sedation, maybe some dissociative symptoms. But again, after those 2 hours, everything goes back to normal. Well, a suitable candidate for esketamine administration will be a person who's been diagnosed with treatment-resistant disorder, that is, has undergone 2 adequate trials of your oral antidepressant medications, the traditional medications. Another would be, of course, if you don't have any allergies to esketamine. Number 3, if you don't have any intracranial hemorrhages or any strokes, that would be. Another, of course, will be uncontrolled elevation of your blood pressure or hypertension. Of course, we have to make sure that you have to make sure that your blood pressure is controlled. So then it will be a sit down with your attending psychiatrist, and your attending psychiatrist will be able to tell you, hey, you're actually a suitable candidate for esketamine treatment, and we would be able to, to afford or do that procedure for you. Okay. Well, some potential side effects from esketamine treatment would be, of course, elevated blood pressure. Another will be sedation. And number 3 is what we call dissociative symptoms. Dissociative symptoms is similar to, the patient would actually tell us, Doctora, I can actually see myself, observing myself actually taking the esketamine. It's like an out-of-body experience. So those are the 3 things that we actually look out for. But again, after 2 hours, all of it disappears. As the medication goes out of the system, all of those symptoms actually also go down. So it's like a wave. It goes with the medication. So usually, my staff is there, I am there. We actually monitor the patient for like 30, 60 minutes, 90 minutes, 120 minutes, 2 hours, just to make sure that everything's okay. And of course, we won't let you leave the hospital unless everything's okay. So usually by 2 hours, you're good to go. Of course, you need to have a person with you because we don't want you driving. We want you to be able to rest after every treatment of your esketamine. So those are the potential side effects, but so far, we haven't experienced any. The most that I've experienced with my patients would tell me is that more of dizziness and a little bit of sedation, but that's it. And it's very helpful if the doctor or the nurse is there, so that the patient would actually say, Doctor, I'm actually feeling a little bit lightheaded. So they're already reassured because the healthcare professional is there, would be able to do something about it. Advice regarding patients with treatment-resistant depression. Number 1, always ask your attending psychiatrist, what are the options available for you? What are the plans for you? So you could also, and this I will always emphasize with my patients, stress to them that, hey, doctor, I actually found this new treatment. This is esketamine. Am I warranted for this? Is this warranted for my condition? Always have an open dialogue with your psychiatrist. You have to be comfortable with your psychiatrist so that you are comfortable asking him or her questions. And the thing is, you're comfortable asking your psychiatrist questions about your treatment, your psychiatrist should be able to answer you because that is how it works. That is the basis of what we call a patient-doctor relationship, a very good patient-doctor relationship.